시청자 여러분 안녕하세요.
Greetings. This is Prosthodontics on Friday Night Live. I'd like to extend my New Year's greetings celebrating 2023. This is the 52nd lecture. We've been having lectures every Friday, and I look forward to providing more meaningful Prosthodontics on Friday lectures to you. To celebrate the first lecture in 2023, we have special guests today. Honorary Professor Choi Deok-gyun of Gyeonggi Dental University and Honorary Professor Jeon Moon-gyu of Yonsei Dental University. Greetings. Thank you for coming to Prosthodontics on Friday. Thank you for inviting us. In the first half of this year in Prosthodontics on Friday, we're going to focus on full denture. The theme is back to basics. The two professors have majored in full dentures. Before we go into lecture, could you give a word of advice as to why full dentures are important in doing prosthodontic treatment? The fact that patient is edentulous is that the quality of the patient's life is very bad. Masticatory function plays a very important role in brain health. Although full denture may not be fully able to replace natural dentition, we need to be able to provide a prosthodontic treatment. The basics and principles of prosthodontic treatment stems from full denture treatment. The principles of occlusion stems from full denture treatment as well, interarch relation occlusion, aesthetics. These all derived from treating fully edentulous patients. In order to provide good prosthodontic treatment, we need to understand the basics of providing treatment for fully edentulous patients to be able to do everything else good. Thank you for your words of advice. When we provide dental treatment, most people think of prosthodontic treatment when they think of dental treatment. Treating fully edentulous patients. This is the basics of all prosthodontic treatment, and the level of difficulty is the highest. That's why treating fully edentulous patients has been chosen as the grand theme of Prosthodontics on Friday. Today, we're going to talk about diagnosing and providing treatment plan for edentulous patients. First, Professor Jeon Moon-gyu is going to talk about the aging society and oral health, and Professor Choi Deok-gyun is going to talk about conventional treatment for fully edentulous patients. And I have prepared a short lecture myself as well, and I'm going to talk about digital treatment for fully edentulous patients. I look forward to your lectures, professors. Those of you watching the program from Dental's site, you can participate real time via the chat. Leave your questions and these will be addressed. It will be done real time and Starbucks coffee coupons will be sent. Among the questions raised, the best questions will be given a special gift. The top 3 people will be sent Mucent Music Tiger Dental Set. Learn about prosthodontics and win your gifts. I look forward to your avid interest and participation, and let us begin today's Prosthodontics on Friday seminar. Thank you. The first theme is aging society and oral health. In treating elderly patients, the most important is our attitude. We need to look back on ourselves. If I am not a fan of elderly people, then you should not get involved in elderly treatment. The reason being, your sentiment can be very quickly translated to the elderly patient, leading to not so good results. Age. This is something that we all know, so I'll skip. If we look at female population in Korea, we have already reached the super-aged society. By 2050, 40% will be elderly population. That is the forecast. If we look at the average age, in 2020, it was 43.7 years old. In the case of Vietnam in Northeast Asia, it's below 30s. We're becoming non-vital country, and since last year, our population is decreasing, and within 100 years, it's going to decrease to 10 million, and about 200 years later, it's going to be down to 1 million. In population, we're going to be the first country to disappear on Earth. The life expectancy in Korea is 83 and healthy life expectancy is 73. What is important is healthy life expectancy. Living healthy is important. The life expectancy itself is not really important. Lying in bed for 10 years, it's excruciating for that person and it's excruciating for the society as well, and there can be many problems. This is mentioned in the media every day, but the top 3 problem of South Korea is low growth, low birth, and aging society. If you look at the graph, shown in red is the time point when South Korea shows negative growth. And it's quite soon. The total fertility rate to maintain population needs to be 2.1, but South Korea is already 0.7. South Korea has tendency to try to be number 1 in everything, be it good or bad. So it's 0.7 right now. Age group divided by UN and WHO. Up to 17 years old, you're underaged, and up to 65, you're classified as young. In that sense, I've only become middle-aged for 6 years. Up to 79 is middle-aged. In order to be classified as old, you need to be over 80. Such times are already here with us. This was released by Joseon Daily about 7-8 years ago, and in Korea, those in 60 to 75 are classified as new middle age. They feel that they're so young and want to work. If you look at Peter Drucker and others, they say that their life truly started after 60s, and Professor Kim Young-seok mentions that from 65 to 75 was peak of his life. The conclusion of Professor Kim Young-seok is that even if you get older, you need to read and learn. You need to do something. That is emphasized. Professor Jung, I have also read Professor Kim Young-seok's book, and I've also watched the TV series in which he appears. What he speaks really resonates with me. Professor Lee Si-young, who's over 90, emphasizes the relation between health and economic freedom. You need to eat less, move more, and you need to be financially independent and be considerate of others. These days, a lot of people talk about frailty. Frailty refers to abnormally fast aging, and we talk about oral frailty. Oral health and systemic health are closely related. Oral health needs to be good for systemic health to be good. As Professor Che has mentioned, the masticatory function and oral health needs to be good for mental health. There are such reviews. This is a checklist from Japanese university, and if the score is over 4, then you're classified as oral frailty patient. As mentioned earlier, oral health and systemic health are very closely related, and if people have good oral health and systemic health, then the life quality will be very good. When we compare people living with their spouse and those living alone, those living with a spouse have better oral health and systemic health. Being alone is not good for you. For the elderly, in order to maintain oral health, you need to be able to brush your teeth well, and it needs to become your habit. Brushing your teeth right after having food and receiving checkup every 6 months is very important. The problem here is that there can be anatomic issues, loose contact, and gingival recession. Due to increased interproximal space, there can be a lot of food impaction. If you look at biological considerations, people have less saliva, so self-cleansing cannot be done properly. In terms of physical consideration, their eye conditions are not as good, and their strength in hand is not very good as well, so brushing itself becomes a problem. Finally, caregiver issue should also be considered. A lot of people rely on caregivers, but if the caregiver doesn't brush teeth often, then he or she won't brush their patient's teeth frequently as well. Whether or not the caregiver has good concept of oral hygiene is important. Next, let's look at demographic imagination. When we forecast the future, we need to anticipate how the population is going to change and come up with a plan to respond to it. In the future, over half the population will be elderly population, and half their spendings will be medical expenditure. Running a dental clinic without treating elderly patients means that you're going to forego half your income. In order for our society to become a healthy society, the elderly needs to be respected. If a lot of elderly are sick, the burden falls on young people. Then it becomes a tragedy both for the elderly and the youth and the society. The elderly needs to be healthy for the society to be healthy. As mentioned, the treatment cost, over half will come from the elderly population. This is the final slide. We're prosthodontists. There's difference between natural dentition and prosthesis made by people. The first thing we should do is to preserve the natural dentition as much as possible, and if this is not viable, we need to provide good replacement for the patient. That is our role. Thank you. This is the end of my lecture, and next there's going to be a great lecture given by Professor Choi Dae-gyun under the title Conventional Treatment Plans for a Fully Edentulous Patient. Thank you. Today I'm going to talk about overall considerations we need to make when treating fully edentulous patients. There are many deterministic factors in providing successful treatment for fully edentulous patients. Impression, the appropriate vertical interarch relations, taking right CR and horizontal interarch relations is very important. Elderly patients. If the health condition of 30-year-old is 100, with age, the functions are deteriorated. When we treat elderly patients, there are many difficulties, and the level of difficulty is similar to that of treating disabled patients. Bodily function deterioration occurs very frequently. The same functional deterioration occurs in oral cavity as well. As a dentist, among many difficulties, the patient's ability to adapt falls down very significantly, so we need to pay more attention. We need to pay special attention. Alveolar bone resorption. We are aware how it is resorbed. The upper always grows smaller compared with lower. When we determine the position of artificial teeth, we need to consider the basic factors. That is very important. As shown in this slide, if there's severe ridge resorption to the level where implant treatment is not possible, there's no special answer. In this case, you shouldn't proceed with treatment yourself, but refer the patient to university hospitals. If you think that implant treatment may be possible in most cases, you can get okay results with full dentures. The patient will be able to continue on with day-to-day life with full dentures. When we look at alveolar bone, photography is very important rather than bumpy. We are aware that smooth surface is more favorable. As shown in the slide in the middle, you can tell that the patient with good ridge is much better than thin ridge. Being flat, as shown in the middle, it's okay for you to attempt treatment, but if you look at number 3 in the middle slide, the sloped mandibular ridge, in this case, don't proceed with treatment yourself, but refer the patient to the university. Rigid ridge which is parallel to the occlusal plane is favorable. If it is not parallel, you need to sufficiently explain to the patient ahead so that the patient is aware the prognosis may not be so good. If there's inflammation in the residual alveolar bone, you need to heal the inflammation first. If you look at the slide, due to full denture, there was severe inflammation in the residual ridge. In general, you would use tissue conditioner to heal the inflammation. You need to proceed with preliminary impression first. This is repeat of the same. You need to heal the inflammation first and make the soft tissue healthy before proceeding with treatment. We're aware that taking impression is very difficult, and that's true. It's not hard tissue, and it's soft tissue, and it moves. Therefore, it's difficult to take impression. Yes, it is correct that you need to take accurate final impression, but we need to take a good preliminary impression as well. But this is largely overlooked. If you don't do this, then you will not be able to get good final impression. If you do a good job in preliminary impression, you can get better results. I believe that final impression depends on preliminary impression by about 80 to 90%. I hope you take into account of this point. You cannot get appropriate final impression with roughly done preliminary impression.
불가능하다라고 말씀드릴 수 있겠습니다. 그다음에 이제 종의치의 그 적절한 재정 인상이라는 그 소위 말하는 적절하다는 얘기는 상당히 정의하기가 힘들긴 합니다만 그냥 대체적으로
Taking appropriate impression. It's very difficult to define. So this is a slide that I've created. When we look at the top far right slide, the one in the right is perfect, the middle is appropriate, and what is on the left is inappropriate. Good preliminary impression and model. If individual tray has been made from it, the final impression size needs to be similar to that of individual tray for it to be appropriate. If you have appropriate final impression and if you adjust the occlusion perfectly, then you can come up with a good denture. Next is interarch relations. Vertical issue is a problem, but horizontal interarch relations, the so-called CR, needs to be registered. This needs to be done accurately. The denture on the far left is the former denture, and the one next to it is the new one. The ridge was fully flat. Take a look at the denture base. The interarch relations was taken wrong. The CR was taken wrong. So if you look at the bite and the impression, if you register interarch relation wrong, then it will be difficult to function and it can cause pain. In registering CR, accuracy is very important. Just okay is not good enough. You need to take accurate CR. Guiding CR in the lower. I use chin point manipulation frequently, but people find it difficult, so I recommend using tongue to palate method. If you do this, you can do a good job.
여기서 우리가 중심관계, 그러니까 악관관계를
The reason why we cannot register interarch relations well is because of many reasons, but one of them is because inappropriate impression. Wax rim continuing to fall off can be another major factor. In the lower, it can be difficult, but in the upper, if you can get a good impression with the wax rim, then it will be favorable in registering CR. Occlusion can be an issue. There is a balancing side type contact on CR. In this case, there's premature contact of functional cusps. The sliding point needs to be removed by removing the outer surface of the functional cusp and the inner surface of non-functional cusp. If you look at the below slide, CR state can be transferred to CO without sliding if you move the cusp tip by removing contact of inner surface between functional cusps. Another point, working side type contact on CR. The outer surface of functional cusp and inner surface of non-functional cusp needs to be removed to remove the sliding point to transfer CR state to CO without sliding. This is the basics of occlusal adjustment. You need to be fully aware of these points. Then it will be of great help. To give you an example, if you look at the far left slide and second from the right, upon biting, the upper and lower are ill-fitting because they're sliding. If you look at the image on the far right, the patient is not biting and the upper denture is fit into the residual ridge. In the middle, mounting was done, and if you look at the oral cavity, in the middle slide, when the patient is biting, there's no sliding, so it's a nice fit, and even when the patient is not biting, it is fit. By doing this, we can prevent the pain caused by sliding occlusion. Occlusal contact. I believe that more so than the denture base, I think pain is caused by occlusal issues if it is not solved, and if it is just adjusted within oral cavity, then unintentionally many dentures are made. We need to check occlusion and check where the patient is experiencing pain. Let me summarize. When we take impression, it's done within oral cavity, and this is also the same for taking interarch registration. In the case of polished surface, occlusal surface, so we mount it on the articulator. Anatomical landmarks can be utilized to accurately reflect the polished surface and occlusal surface. Once appropriate impression is taken, and if interarch relations are registered accurately, then we can make a denture that can function and chew very well. Professor Che, can I ask you a question? Impression surface. This sounds as if taking impression is very important. When we make a denture, the basic is impression. Please listen to my question. In order to take a good impression, Professor Che, you believe that fabricating individual tray is important. Yes. I think taking good impression. I don't think impression materials impact the impression significantly. The tray serves a bigger role. I believe that appropriate tray needs to be fabricated first. What do you think about that, Professor Chung? Yes, I agree that the impression comes out following the tray. Personally, what I find most important is the essential stops within the tray, how to keep that position in final impression. Yes, the state to which I've practiced it, but even for me, when I try it multiple times, it's not the same. After removing the stop, positioning it to its original position is very important. Will impression material affect it? I find impression materials with good flow good. It is better to finding the right position. I make a lot of holes so that the excess can fall off, so I tend to use materials with good flow. I agree with Professor Chong that the flowable impression material is important. Thank you for the wonderful answers. Please carry on with your lecture. In the impression surface, all of this is secured. Retention, support, and stability. Just because you do a good job in the polished surface and occlusal surface does not mean that you get more retention. But if you do a poor job here, the retention, stability, and support that have been gained through impression surface will be gone. Your hard work will have been for nothing. The basics needs to be respected, the anatomical landmark. I'm sure you're aware of it because they're test problems. If you can reflect these in the full denture and take a good impression, then you'll be able to form a good denture. Can I make a comment? When we had national exam, the questions would be like, what process is most important in fabricating full denture? I remember that question. Do you remember? Yes. To add, everything starts from good impression. The final conclusion is determined with occlusion whether the patient can use full denture well or not, or experiences pain or not. If you have a good start, you can get good ending, but no matter how perfect your impression is, if occlusion is wrong, then it cannot be used. Even though impression is not 100%, if occlusion is perfect without sliding, then it can be used nicely. Please take note of it. Yes, the starting line determines everything, but occlusion is very important. It's the same thing repeated, but taking appropriate final impression. If the artificial teeth are appropriately aligned, then you can get good full denture fabrication. If interarch relation is accurate, then you can assume that occlusion is good. From the lab, no matter how they do a poor job in doing occlusal adjustment, they cannot make a sliding occur. Inappropriate occlusion occurs because appropriate interarch relation and CR was not attained. Please remember this. Appropriate final impression and alignment of artificial teeth. CR needs to be accurately registered. Then you'll be able to get the functional, aesthetic, and comfortable denture. As I give my lecture, I'm sure you have noticed that I've made a lot of emphasis. I've repeatedly told you the importance. I hope you take note of that as you listen to the lecture. This is the end of my lecture. Now, Professor Cho In-ho is going to talk about digital diagnosis and treatment plans. If you could please. Professor Chung Yu, Professor Choi Do-kyung, thank you for the wonderful lectures. So following the two professors, I'm going to talk about digital denture, which is really receiving the limelight these days. As is with other sectors, I believe that digital dentistry will be the mainstream treatment modality. In treating fully edentulous patients as shown, there is a traditional full denture method, overdenture, hybrid denture, implant-supported fixed bridge, and others. There are different pros and cons for different options. Today, I'm going to talk about how digital dentistry can be merged to fabricating full denture, which has been used for treatment for a long time. What is digital denture? As shown, digital software is used to design the full denture, and a 3D printer or milling equipment is used to fabricate the denture. Compared with the conventional denture fabrication method, the number of patient visits go down, it's more economic, and it's very easy to do refabrication. With the widespread distribution of software and equipment, in Korea, the level of oral scanner distribution is that out of 3 dental clinics, 1 dental clinic owns oral scanner. And in line of such distribution, it's being used actively for fixed dentures. And also, digital dentistry is likely to be applied to removable dentures as well. Conventional denture treatment method and digital treatment method. What are the differences? The biggest difference is the number of visits. If you look at the conventional treatment method, up to the denture delivery, the patient needs to visit at least 5 times, but with digital treatment method, the patient only requires 2 or 3 visits. In the case of conventional method, the first 3 visits are about taking preliminary impression, final impression, and taking inter-arch relations. These can be done at once in the case of digital treatment. Therefore, the number of visits go down significantly. If the patient requires restorations quickly, you can just provide a final restoration without providing try-in. Denture. Treatment can be ended with 2 visits. Let's take a closer look at the workflow in the case of conventional treatment. First day, preliminary impression is taken and is sent to lab. Individual tray is made, and this is sent to the treatment room. Final impression is taken and sent to the lab. With that, base plate and occlusal rim is fabricated. Vertical dimension and CR is checked, and the information is sent to the lab. The lab sends over the artificial denture. On the 4th day, wax rim is tried in, aesthetics and occlusion is checked, and then we make requests to the lab for adjustment, and then the denture is sent again to the dental clinic. There are a total of 5 steps, and it takes over 5 days. In the case of digital dentistry, oral scanner is used to scan the oral cavity. This is not frequently used. Final impression is taken and impression material is sent or plaster is done to send the model. The lab uses model scanner to scan it and design it. Base plate and artificial teeth are designed. Temporary trial denture is fabricated. The denture is tried in if it is open bite or if the teeth length is excessive. Aesthetic adjustments are made and occlusal adjustments are requested. The lab adjusts the file and uses 3D printer or milling machine to fabricate denture. In this case, it requires 2 visits or more. If you don't do trial denture, the visits can be limited to 2. When we mill digital denture, we can separately mill the denture base and artificial teeth and then bind them using resin. This was frequently used up until now, but as of now, resin blocks are available. The pink is used to express the denture base, and the yellow is used to express teeth. The block can be milled at the same time, so rather than milling the denture and teeth separately, you can do it at the same time. There are different printing machines. In Ostem, there's 1mm4X, and from Ivoclar, there's Program Mill, and there are different milling machines from different companies. There's 3D printing, which is not milling. In the past, the printing material strength was weak, so it was used for temporary denture, but these have been improved significantly and can be used as the final denture. From Ostem, there is one-jet DLP. I believe more advancements have been made on one-jet DLP compared to other milling machines. You can see that 3D printing devices have made many improvements. Let's look at pros and cons of conventional denture and digital denture. Pro for one option can become a disadvantage of the other option. So let's look at pro of digital denture. Convenience, standardization, and consistency. The number of patient visits go down, and the lab no longer has to pour plaster, and the lab work is much reduced. Because the number of visits are reduced, it is more convenient for the disabled and elderly patients. Standardization, if there's a denture fracture, it can be refabricated very easily. The digital denture system, which is widely known in Korea, is Denka system. I'm sure you've heard of it at least once. It's Denka system. Professor Kim Tae-hyung of USC LA and Mr. Kwon Sun of the lab worked together to form this company. Originally, we used to use flasking, but now 3D printing is used. Probably not that many dentists in Korea have used it. I'm sure there are a couple of dentists who have done it across the world, and I have experienced myself when I was working at Dankook Dental University. Evident in Arizona, USA. Milling is done, mostly. There's Evident system. There's Evolution denture system from Ivoclar Vivadent, which is quite advanced. Denture base and artificial teeth are milled as one. They're not milled separately, so there's no need to bind them. This is a company with such a system. Dentsply Sirona denture system. There's a digital denture system. In Ostem, we are working really hard to develop software program for digital denture. Soon, one denture is going to be released, I hope. I expect this to be a very easy-to-use software for dentists. If you look at the size of the 3D printed digital denture market in 2021, it was $190 million, but 5 years later, in 2026, it will double to $20.3 billion. It is expected to grow dramatically. We've seen how it can really exponentially grow with implant. When I first placed implant, about 5% of dentists placed implants. Now, most dentists place implants. In that context, within 10 years, digital dentistry is going to dominate the dental world. I have high expectations and concerns as well. I have mixed feelings. In treating fully edentulous patients, we need to consider this factor. This is the end of my lecture. Thank you for listening. Dear viewers, the three of us have given lectures under the grand theme of diagnosing and treating fully edentulous patients. So we have talked about aging society and oral health, conventional treatment methods, and digital treatment method. I'm sure there are many real-time questions that are up. I look forward to your continued interest in the Q&A session. I look forward to your participation. Let's check. Let's look at the real-time chat screen on Dental site. First, ID KKK. I rushed here as soon as I received the Kakao Talk alert. Today's the day we watch prosthodontics on Friday. I have waited a lot. There are many words of encouragement. There is a question about overdenture. Overdenture will be addressed in the later part of the series. Thank you for the question, but this will be addressed when we provide a lecture on overdentures. Is there a way to do good job in making BPS denture? This is about BPS denture. Dr. Lee Hoon-jae is going to address BPS denture. So if you could raise your question then, that would be great. Professor Choi Dae-gyun, you have a great voice. Thank you. Head guy, 1, 2. If the patient has been fully edentulous for a long term, the patient tends to protrude his or her chin, leading to inappropriate bite in the posterior area. How can I solve this problem? Professor Choi, do you have this experience? If the patient has been edentulous for a long time, the patient pushes his or her chin forward. We see these kind of instances. There are patients who protrude their chin. If you can do good guidance, then that'll be good. I've explained it briefly. If you try tongue to palate method, we're all aware what the tip of the tongue is. You have the patient use the tip of the tongue to touch the palatal pit. You have the patient open their mouth and stick their tongue in the palatal area and then have the patient close their mouth. According to research, it is in line with CR. There are such studies, so you can try that. Patients are not aware of the soft palatal area, therefore, you need to add something like a UTT wax in the palatal pit area and have the patient stick their tongue towards it. In that state, have the patient bite, and in order for this to work, there needs to be retention in the upper. So it's easy to get retention in the upper. In the case of lower, we need to fixate it. Fixation is required in the lower, so towards the buccal shelf, press your forefinger and then with your thumb, press the chin point. In that condition, have the patient bite. You have the patient touch the UTT wax. In this case, you can see that the patient bites in CR state. Do you push slightly? Yes, it doesn't really matter. You need to make sure the patient touches it. In this case, the mandible is in retruded position. Another point is the same method, but if you have the patient position their neck towards backwards and pull the mandibular muscle, once the mouth is stretched and closed, it does not close in CO state. If you press it hard using thumb, then it will become CO. You need to check the position you get with the position you got from the tongue to palate method. I'm sure you're all dentists and will be able to know it, but in the common area, the patient will be biting. In other words, tongue to palate method is of great help in CR guidance. Okay, thank you. Next question. Professor Jung, can you answer please? ID wonderful. If the patient has been fully edentulous for a long period or has been using denture that does not fit properly, in that case, the mandible is protruded upon biting. In this case, when we fabricate new denture, is there a way to reposition the mandible in normal position? When I try to register bite, the patient tends to bite protrusively. As Professor Che mentioned, I would like to point out that bite check, bite registration is wrong expression. It's a jaw relation because there's no bite. It's jaw relation. So I use 3 different methods. Let me explain. First, I explain to the patient. I tell the patient what position I want. And after that, in the anterior area, I remove contact in the rim. I just leave the posterior area. Third, I believe relaxation is very important. If the patient is relaxed, hinge movement can occur. If the patient is not relaxed, then it just won't happen. I use these 3 methods. Also, do you have the patient practice more? I think patient relaxation is most important. You need to provide thorough explanation and tell the patient exactly what I want. I ask the patient to close their mouth. If you do this, you can get hinge movement. Next, polar bear. Among Professor Choi Dae-gyun's lecture, when there is not so good flabby tissue or soft tissue condition, Professor has mentioned that the situation needs to be improved before taking impression. In the case of flabby tissue, should it be removed first, or should I pay attention so that pressure is not applied there? In my opinion, dentist needs to make a decision depending on how much flabby tissue there is. If it is too excessive, but if it's not a big deal and if the patient has systemic disease, we can leave it as is. We need to consider whether the patient has any systemic disease. This needs to be determined by the dentist. So what kind of criteria could there be? Criteria for making a decision. You need to take a closer look. I think you need to make a decision based on how much movement it has. If there's inflammation on the flabby tissue, you need to heal it, and you need to determine how much the flabby tissue moves. If the amount of flabbiness is not excessive, it's difficult to pinpoint numbers, but if the condition is not really bad, you can just deal with inflammation and proceed. But when taking impression, you need to make sure that that area is not deformed. You need to make sure pressure is not applied here. You can make a lot of holes there, or you can leave it open, like a lid. You can make a lid type for that area. You can utilize this kind of concept when making tray. In my opinion, I believe that it will be frequently observed in upper denture cases. You need to look at how much retention there is. When you look at the ridge condition and make anticipation, If the denture can be fixated despite flabby tissue, then you don't need to deal with it. But if the retention is not good, and if it becomes an issue with stability and retention, then you need to remove it. Professor Chung? You can think of 2 points. If it is in the border, you can remove the offending border and do conditioning. Within a couple of weeks, then it will be removed. In the case of supporting tissue, if the patient is older, it's not easy to do surgical intervention. As mentioned, you need to take impression with the flabby tissue. It hangs, so at times it can be deformed. You need to add a lot of wax on that area and make a lot of holes so that impression is taken as is. First, you can take impression without that area, and then later you can use impression plaster to register that area. You do painting. That's not easy. Finding the right position and applying it is not easy, so you need to take impression so that deformation can be avoided. Kongbori, what are precautions in registering bite for fully edentulous patients? This has already been addressed by Professor Chong. Professor Che, in normal state, when we take bite, Professor Chong has mentioned about when it was abnormal. What are the things that we need to look out for when things look normal? When I take a look, due to COVID, when we study and listen to each other, when I meet with graduates, taking jaw relation. So I'm just going to refer to it as bite. When we register bite, the biggest problem is that the wax rim of the upper continues to come off. It's very difficult to take a bite registering both sides. So when registering bite, at least one needs to stay, but that's not likely in most cases. That's very difficult. In the case of upper, we can make a wax rim that does not fall off if we pay a tiniest bit of attention. We need to fixate the lower smoothly and then take bite. I think that is the best option. Taking jaw relation can be difficult, and if you look at books, it talks of jaw joints which we cannot see. But that's the only thing that we can do. The biggest mistakes occur is related to making sure that record base doesn't fall off when registering bite. This needs to come first and then use tongue to palate method or the methods mentioned by Professor Chung. You need to choose what you can do best. Regardless of the option you choose, you need to make sure that the wax rim does not fall off. Understood? Yellow 8898. Is there a way to take alginate impression without bubbles? This is related to materials, but it's related to taking preliminary impression. It's basic, but we are going to swiftly address it. Professor Chong, how can we avoid bubbles? In the case of General Hospital, mixer is used so they can do a good job. You can get good result if you use alginate and then add cold water on the surface and then press it. Alginate requires moisture, so if you apply it, then you can get good results. When we address materials, that is the way to do it. And when you take impression of the upper, it goes up and the bubble occurs where the palate is deep. In order to prevent it, I apply some alginate on the ceiling of the mouth to avoid bubbles. What Professor Yu have mentioned is avoiding bubbles in terms of material, and this is another way to do so. Next, Goku 27. How many implants do you place for fully edentulous patients? If you go to prosthodontics on Friday on Dental's site, there's a lecture on this topic. Please refer to it. Understanding prosthodontics on Friday. There are times where upper posterior palatal seal is not formed using the impression body, but based on experience. In this case, are there some things to check in determining the upper posterior limit? Upon delivery, when determining the upper posterior limit, this should be determined not upon delivery, but it should be done before. I do not believe that they should be done at delivery. I'm full. There's a rubber impression material for full denture. What's it like? Professor Jung, you have mentioned it. Can you emphasize on it once again? These days, polysulfide light body are not readily available. In the past, we used to use it very frequently for several decades. It's really great. Rubber impression material for full denture, what should we use? We need to use material with good flow. It should be almost pouring. You need to use material with good flow in order to avoid pressure. Thank you. Uza, what is tongue-to-palate method? Professor Che, to explain you once again. Tongue should touch the soft palate. In that state, you need to have the patient close mouth. That is called the tongue-to-palate method. Then you can get the CR guidance. That is how you take a CR. ID Kyonu, in taking final impression for full denture, which impression material do you use from which company? It's difficult to discuss on the program. There may be some complaints, so if you reach out personally, answers will be provided. It's difficult to address in the program. Goku. So the question is slightly off topic. So we'll address it in next time. Kongbori, do you always use individual tray when you take impression? For fully edentulous patients. Professor Che, yes. I do too. Individual tray is used always when treating fully edentulous patients, and this is strongly recommended. Goku 27. In the case of elderly patients in their late 60s, if they're fully edentulous, should we not just consider implant, but also need to look at different examinations in observing different diseases such as diabetes and hypertension? I'm unsure as to what this question is about. Doing denture without implants? If there are contraindications such as diabetes, in most cases, full denture will be used. We'll review this question later. Kyonu, do you use clinical mounting for occlusal adjustment? In my case, I do it all the time. You do clinical remounting. I do chair-side remounting. What do you mean by chair-side remounting? Once the denture is complete, I do try-in and I check bite once again. I do mounting, and at chair-side, I do occlusal adjustment. Understood, Professor? Professor Chung? Theoretically, it's right. We need to do remounting, but that's very technically sensitive. If you do it wrong, then it can be more distorted. Final adjustment needs to be done within oral cavity. That's the best way to go forward. Final restoration. Articulator is hard base and oral cavity is soft base. No matter how you try, it's different. Final adjustment needs to be done. Regardless of the method you use, you need to do it within oral cavity. Professor Che uses clinical remounting and do occlusal adjustment, but then you need to do check once again. Kongbori, how many times do you take impression? In general, 2 times. Preliminary impression and final impression. I'm not sure as to the intent of the question. Registering final impression for full denture. Do you do impression making? Yes, making, not taking. Nuriho, how do you form anterior and lateral guidance? Arbitrary mounting using articulator. How should I do it? You need to check a bite. Beyond just checking bite, I believe this will be in the textbooks. 30 degrees, 15 degrees, and so forth. You need to look at the textbook. Look lala. Professors, you're awesome. 2 professors seem to be awesome, but 1 person not so much. Kyonu, when fabricating full denture at first, taking impression was difficult. Next, taking jaw relation was difficult. And then occlusal adjustment became more difficult. With time, patient management became most difficult. Do you agree? Do you relate? As I mentioned at the very beginning, the relation between patient and the dentist is very important. If you do not have trust in your relationship, you shouldn't begin treatment. The elderly patients, they don't really speak it out loud, but they're very quick in terms of catching how others feel about them. Once you put in the mirror, the patients will know whether you're confident or not, or whether you like them or not. Forming good relation is very important. Having trust is very crucial. What do you think, Professor Che? If you're at that level, all you need to do is manage your patients. You have overcome the difficult challenges, so that's really fortunate. Yes, managing patients is very important and difficult, and I've been serving as dentist for a long period of time and have been providing full dentures, but sometimes you get the sense that you don't really click with your patients. In those cases, it can be very difficult. I agree that patient management is most difficult. It seems that you're at a level where you have overcome most of the other difficulties, and that's really fortunate. I hope you navigate through patient management wisely. Winter wind, is it clinically safe to use a heavy body rubber to do border molding first and then to do wash with light material? So doing a heavy body first and then using light body. I don't think it's not too bad. What do you think, Professor Jung? Doing border molding using heavy body. Personally, I've never used it. I rarely use it. It's too tough, and I use medium body for border molding and take final with light body. I've hardly used heavy body. If the ridge is good, at times it can be difficult to remove. What about you, Professor? I have no experience using heavy body to do border molding. Doing border molding at once. One-step border molding. One-step border molding material. Doing a border molding at once. Perhaps it can be possible for the upper, but I think it will be tough. Border molding, even if you do it, the result won't be good. If you are doing it just for the pretense of it, then okay, but in order to do good border molding, that is not the recommended way. Perhaps some people can do it well, but still, If you do it just for the sake of it, perhaps that can be understandable, but doing it when you're trying to do a good job, that is not recommended. There are many questions, so we need to skip through. Polar bear, how can I get appropriate CR guidance? Professor Che, what kind of method do you use for CR guidance? The method that I've recommended is chin point manipulation. So you guide the chin and achieve CR. And a lot of people say this is difficult. So you do chin point like this or from the back, from the side. You hold the lower like this and then make CR. Professor Jung? So I don't do these kind of methods because the patients tend to protrude. I don't use my hand. I explain to my patients. I explain what hinge movement is, and once patient relaxes, patient can get it. CR. Horizontal jaw relation, vertical relation. I don't use my hands. I just provide my explanation to the patients and have the patient do it themselves, because at times when I do it, it works, but then when the patient tries it, it doesn't work. That's just not right. So you need to have the patient understand and do it themselves. And the patient has to relax. So for beginners, you need to choose the chin point technique. There are so many questions. We have limited airtime. There are very good questions. I don't know what to do. Shall we respond to all of them? I'm worried. Shin 8234, when you guide a CR, the patient puts in too much force, and even when I do deprogramming using cotton roll, in order to offset the patient's force, the dentist puts in too much force, resulting in inaccurate guide. Is there any way to solve it? As Professor Chong has mentioned, you need to explain well to the patient, and the best is for the patient to find it. You need to have the position where the patient can reproduce it. Shadow Dina, it's maybe very rare, but after providing denture, the patient complains that the jaw just won't stay in place and continues to shudder. What is the cause of it? We will address this question next time. High-end, when taking preliminary impression for upper and lower full denture, they say that it is better to mix less water than the manufacturer's recommendation. Why is that so? I'm unsure of that method. It will become dry. I think it is to do overextended impression, but I don't think that's a very good method. Professor Che? I do it frequently, so let me explain. If it is too watery upon the slightest touch, it collapses. However, if the flow is slightly less, about 5% less water compared to the manufacturer's recommendation, then the flow would not be as good. The preliminary impression will be like overextended impression, and if you do light border molding in alginate state, you can get fairly good impressions. I tell others not to make it watery. I always say either follow the manufacturer's recommendation or, if possible, use 5% less moisture. Understood? Next, to polar bear. Even if you use digital technology, you need to do final impression after preliminary impression. Is that right? Yes, final impression needs to be taken, of course, if there is individual tray. Kyonu, can final full denture be printed with 3D printing? Yes, it's possible these days. Mix, it's the same reason. I feel really attracted to digital dentistry. I believe so. There are so many questions. There are numerous questions. I think many people have raised questions. Perhaps we need to have another lecture. We need to talk with the staff. There are so many questions, and we apologize for not being able to address them during the program. Because we have limited time, we were unable to address all the questions. We will end the Q&A session, and as for the rest of the questions, they will be divided among us three, and answers will be provided. So please answer the questions that you've been assigned. Yes. I would like to extend my gratitude to those who have participated in the chat, raised questions, and left comments of encouragement. Now we will choose the best question that have highlighted prosthodontics on Friday. We will select the 3 people, and a Vusim Music Tire dental set will be sent. Professor Che, can you name your pick? I chose 3 people. You need to choose one person. I'm going to choose Gongboi. Professor Chung? I'll choose Winter Wind because it's cold. Winter Wind. I personally am divided between 2 people. I'll choose ID Kyonu. The lucky winners, ID Kongboi, Winter Wind, and Kyonu. Congratulations. Separate contact will be made to the winners. As for the winners of coffee coupon event, text will be sent on Monday. The coupons will be sent along with it. Don't feel too let down for not winning the event. The real chat event continues on in the prosthodontics on Friday night. So I look forward to your keen interest. There have been so many questions up until late. Many people are studying really hard, and I'm really passionate. Can you give words of encouragement to our peers and younger dentists who are studying really hard? As I've mentioned earlier, I've talked about Professor Kim Yong-seok's conclusion. Regardless of our age, we need to read a lot and learn and work. I hope you continue on with such thought in mind. We need to continue on with our study. Professor Che, regardless of full denture or RPD, there are extreme basics. For instance, on top of my mind, if there's ridge resorption, in order to find the original position of artificial teeth, utilizing anatomic landmarks. Such basics needs to be respected. The areas we studied hard when we were preparing for the national bar exam needs to be reminded. You need to be able to reflect that in your clinical practice. That is the best way to do nice job in full dentures, and that is in line with the grand theme we have at prosthodontics on Friday, back to basics. Ladies and gentlemen, how did you like the first prosthodontics on Friday seminar in 2023? I believe many people have raised questions and showed keen interest. We have now begun the Back to the Basics Full Denture series On March 3rd, Professor Kwon Keung-nok is going to talk about how to take a successful impression in the fully edentulous upper. And March 31st, Professor Kim Jong-un is going to talk about how to take successful impression in the fully edentulous lower. And on April 14th, Professor Kim Hee-jung is going to talk about retention and stability of full denture. Dr. Lee Hoon-jae is going to talk about BPS denture fabrication. Professor Lee Myung-jun of establishing vertical dimension. Professor No Kwan-tae of establishing centric and normal relations. And in the last lecture of the first half of 2023, Professor Park Sang-won is going to talk about the bilateral balanced occlusion. In the second half, we're going to talk about setting the full denture and different complications and how to address them. There's going to be 12 lectures on full denture. We have a really interesting curriculum in the first half of 2023, so I look forward to your keen interest. I hope you got some meaningful clinical prosthodontic tips today, and the questions that were raised but not answered today will be divided among us three. We will return with a better and more interesting content, so stay tuned. Thank you. Good work. Thank you.
수고 많이 하셨습니다.
네, 감사합니다.
네, 수고 많이 하셨습니다. 네.